Hi, everyone. My name's Doug Owens. I'm the Director of Stanford Health Policy here at the Freeman Spogler Institute of International Studies and the Chair of the Department of Health Policy in the School of Medicine. And it is an incredible honor to introduce a friend and colleague, Dean Winslow. Um, Probably needs no introduction, but there may be things that Dean has done. There's so many that you might not all know about. And so I'm going to take a little bit of time just to talk about some of the things Dean has done. So Dean's a professor of medicine with appointments in the Division of Hospital Medicine and Infectious Disease. He's a senior fellow here at CSAC. He's served on the Stanford faculty since 1998. He was at one point the co-director of the Infectious Disease Fellowship, among many other leadership positions. He was chief of medicine at Santa Clara Valley Medical Center. He's done so many things. I looked at his name, and he had many initials after it that I didn't actually even know what they meant, but I think I may have decoded some of. He's a master of the American College of Physicians, a fellow of the Royal College of Physicians, the Infectious Disease Society of America, and the Pediatric Infectious Disease Society. He's written many papers. He is also a colonel, and he was in the Air National Guard since 1980. He served as the Air National Guard assistant to the commander of the 55th Medical Wing. He deployed to the Middle East 6 times between 2003 and 2011 as a flight surgeon supporting combat operations in Iraq and Afghanistan. From January through April of 2003, he was the flight surgeon responsible for combat rescue operations from Tikrit in northern Iraq. In 2005, he coordinated the military public health in Louisiana in the aftermath of Hurricane Katrina. In 2006, he served as an ER physician with U.S. Air Force 44th 7th Combat Hospital in Baghdad. And in 2008, he served as the hospital commander during the Iraq surge. He is a 2007 graduate of the Air War College. He served as an infectious disease consultant to the U.S. Air Force Surgeon General. Dean has 1,150 military flying hours, including 431 combat hours and 263 combat sorties. He has extensive operational experience in fighter, tactical airlift, and combat rescue missions. He holds an FAA airline transport pilot license. Not on his bio, I do believe he might be certified to fly 737s. Is that right, Dean? So if you need somebody to take you somewhere in a 737, Dean is your person. Also, since 2006, he's arranged medical care for Iraqi children. In 2015, Dean and his wife, Julie Parsonette, created the Eagle Fund of Silicon Valley Community Foundation, which provides aid to Middle Eastern and Central American refugees. I really almost never say this or use this phrase, but I do think that Dean is an American hero, and it is such an honor. Dean,
thank you, Doug.
thank you. You're so
That's
welcome.
a very, very sweet introduction and really undeserved. So anyway, thank you, Scott, for inviting me to give this talk today. And I've really kind of been looking forward to doing this. As many of you knew, I was on unpaid leave of absence from Stanford for a year and a half, from basically March of 21 until July of last year. So I wanted to talk a little bit about what I was doing. Also, anyway, I had no conflicts of interest to declare. So what main part of this first talk that I wanted to give is to understand the overall purpose and objectives for the testing and diagnostics working group. This So anyway, this was actually photographed. Of course, the play has changed a little bit, but when I took over here in this was May of 2021, we had a 40% $1.6 billion budget. I'll talk a little bit about what we did with that money. And had 82 people that reported to me. And so these folks were not all from CDC. There were about 30 from CDC, maybe 10 from the FDA, another 20 from DOD, who were responsible for a lot of the larger procurements, particularly those that went into the strategic national stockpile. Had folks from NIH, ASPR, and FEMA, and a variety of other agencies. So it was really a steep learning curve for me to kind of understand, exactly, who reported to whom and how these agencies all operated. But it really was just a wonderful group of people. And honestly, it was a labor of love for me to go in every day and interact with these folks. I show this picture. This is actually the Hubert H. Humphrey building. I don't know if any of you have seen this in DC. But it was built in the 1970s. My son, who some of you have met, is a very sophisticated young man. He's been sophisticated since he was 7 years old. He was like a Brooklyn hipster at age 7, which I don't know where he got that from because I'm his dad. But when he came to visit me shortly after I joined the group in April of 21, he looked at the building and he immediately says, "Dad," he goes, "do you realize that that building is a classic example of brutalist architecture?" And I'd never heard that term, but apparently that does describe this kind of architecture. This is actually a photograph I took from my office window. It was really just absolutely amazing, to be there. And so when I'd have a bad day or I'd get yelled at by the White House, I'd look out the window and go, "Well, hang in there. This is pretty cool that you were asked to help lead this group during this unprecedented pandemic." So anyway, so when I arrived in basically the end of March, at that point already more than 1 million Americans had died of COVID-19. And I remember, one of my favorite places in the world is actually the mall in Washington, D.C. And I love, visiting the memorials along the wall. But it was particularly sad. Again, there's flags, basically, these little white flags corresponding to each person who had died at that point of COVID-19. Also remember when I got there, it was only a few weeks after the January 6th insurrection. And there was a reminder of that, like literally on every block. At that point, there were still 4,000 guardsmen from all around the country that were on active duty in our capital. These are some of the guys that were guarding actually the Humphrey building, and they were armed actually with fully loaded M4 rifles. Very, very, serious at that point in terms of, concern about, additional unrest that could occur. So I always, went out of my way to say hi to them, every morning and when I left as well. So this is just a photograph of me with a few of the guys right after they got off of work. Little bit just the history about the Guard. I think a lot of people don't really know that much about the National Guard. So I thought I'd just spend a couple of minutes and tell you a little bit about that. So again, the National Guard actually predates the federal army, that George Washington had. So all 13 of the original colonies actually had militia, essentially the precursors of the National Guard. So the first Guard unit that I was assigned to in 1980 was the Louisiana Guard. And of course, it was had a little bit of a checkered history because its actually most famous unit was the Washington Artillery, which saw battle and combat at Gettysburg, of course, on the other side, on the Confederacy side. I was in the 159th Fighter Wing, the Louisiana Air National Guard. It's an F-4 Phantom that initially I was assigned to, and then we converted to the F-15 in 1985. So just wonderful memories of getting to fly as a backseater in these combat aircraft. And then the lower right is one of my favorite buddies, Jim Eggplant Cagle. And he's actually, that is no kidding, a real upright piano that's been set on fire that he is playing at a party. And Eggplant came to my birthday party up at the Marines Memorial Club a few weeks ago up in San Francisco. And he's an amazing musician, but he did not light the piano on fire, but he did show up in his flight suit and played it. And it was really special. This was, oh yeah, that was apparently, it was a British tradition that started like prior to World War I or during World War I. And it was because like some officers wanted these pilots, not all who came from an aristocratic background, to play a musical instrument. So there was a while they were actually required to take piano lessons, and apparently a lot of these pilots revolted and burned the pianos. And so apparently that's the origin of this fighter squadron uh, tradition. So anyway, this is the Delaware Guard. So I was in the Louisiana Guard from 1980 until 1995. And then when I moved to Delaware, I transferred to the Delaware Air National Guard. And this again, I'd like to show you like the date on here is when the Delaware Guard was founded was 1655. So it's a full 120 years before the Minutemen marched, in Boston, in Connecticut, or rather in Lexington and Concord. So anyway, that's actually a painting of the Delaware militia in action at the Battle of Long Island, where they're giving the British hell and apparently served with distinction. Then the lower left is a combat mission in Afghanistan with yours truly and a couple of our other Delaware Guard guys. And we had just got done dropping some ammunition and MREs and water for Marines out in Helmand Province in Afghanistan. And in the process, it came really close to getting shot down by a ZSU-23 anti-aircraft gun. So we're happy to be alive, and we accomplished the mission. So we're on our way back to Bagram when that photograph was taken. And then again, the California Guard offered to put me back on active duty, so pulled me out of retirement, and offered to, since it would take CDC months to get me on board as a Title V employee. So I had unfortunately given away all my OCP uniforms when I got back from Afghanistan. So I had to drive up to Travis and buy 2 brand new OCP uniforms, which are a little pricey. But so now I'm in the California Guard for the first time, and it actually had apparently a really proud tradition during the American Civil War when it I think wasn't even part of the Union yet, but it contributed more than 15,000 soldiers to the Union side, including serving actually in the Massachusetts cavalry, where apparently many of them served with distinction. So anyway, I did pay a visit one afternoon when I got off work early to the Lincoln Memorial to say hi to who would have been my boss if I'd been in the California Guard in 1862. So anyway, going to what we did at the Testing and Diagnostic Working Group. So big job, of course, was trying to understand the diagnostic supply chain, including a lot of constraints that we had. And I think many of you remember that, particularly in 2021, basically the world was suffering from significant supply constraints. This included really supply chain problems with things you wouldn't even think about, like cotton swabs or flock swabs that you need for diagnostic tests, microchips, which of course not only are used in modern automobiles, but are also used in diagnostic equipment as well. Our big job really was to not only procure full diagnostic kits, both rapid tests, point of care tests, but also making sure that the laboratory developed tests, actually had the materials that they needed to be able to field their assays as well. We also had a broad, tasking to support state and territorial public health departments, which of course traditionally is something that the CDC does and does well. So it was really fun working with, again, all these other, health agencies around the US and actually in territories, US territories outside of the continental US. Again, I had full access to the amazing, data analysis and data collection capabilities of the CDC, and I'll show you some examples of that in a few minutes. We did actually, work with the White House to draft and convey federal testing policies, including serial testing in congregate settings. So this was really important, particularly in order to safely open up schools, in order to keep people safe in nursing homes, and in prisons and jails. So this was a lot of what we worked on as well. And then, the last thing, of course, which was sort of an aspirational goal, is to be better prepared for the next outbreak. And actually, David, I wanted to congratulate you on your book that just came out, where you think much more thoughtfully, than I did certainly at the time, about what we need to do to be better prepared for the next epidemic. So this is again just kind of a little bit of a repetitive slide. So understanding supply and demand in the testing landscape. Again, our group, which was this interagency group reporting directly to the White House, it was set up to manage the U.S. government efforts to expand testing capacity, and then also to provide rapid response and then conduct analysis and policy. And I'll go into that also more. Um, we actually, one of my favorite people that I worked with actually was on loan to us from the NIH. His name was Steve Santos. And Steve's job was really to talk every day to our industry partners, find out what constraints they were dealing with, how we could help, and then also kind of give them a heads up about potentially purchases of over-the-counter point-of-care tests, as well as give some of the larger laboratories heads up on what could be expected down the line in terms of our operational testing programs using laboratory-based testing. As I mentioned before, one of the things I really enjoyed was engaging with state and territorial public health departments, as well as other U.S. government agencies, including the Bureau of Prisons, to make sure that they had diagnostic tests available to them. And then, I think everyone knows that the amount of immigration, largely from Central America, dramatically increased during the Trump administration, despite the threats to build the wall and the harsh treatment of immigrants and refugees, that actually they were at much higher levels during the Trump administration than during the Biden administration, and particularly the increase in children, unaccompanied children, was something that got all of our attention, and that was one thing that my group was asked to take the lead on in terms of infectious disease, and particularly COVID-19 testing of these children. I did use some of my money for funding some serology research, both at through NIH, that went out as grants to people, including in academia. Um, and I'll talk a little bit more detail about the CTS budget, and this was to provide testing capability and access to underserved populations. And I'll again go into more detail in that in just a minute. The two main operational programs that I had oversight of in 2021 were what we called ICAT, which stood for Increased Community Access to Testing. And these were largely public-private partnerships. This included Southwest Border, K-12 schools, as well as pop-up testing. And again, I'll talk more about that in a second. And then the other large program, ICAT, was again about a $12 billion program, and Operation ET, or expanded testing, was a real effort that I felt really strongly about. My mom was a public school teacher for almost 40 years, and just how much really, particularly small children, but even older children and university students, because when things were shut down, there weren't the opportunities to socialize and learn skills and things that are really important for children to have. So one of, again, our priorities with Operation ET was to basically provide free testing to schools, K through 8 schools, focusing initially anyway on areas of high social vulnerability, basically poor areas that really needed it. But we didn't really deny this free testing really to any school district that wanted to take us up on it. So again, that was a real big priority. And then long term, the industrial base expansion was a major goal of the Testing and Diagnostic Working Group. We also did, responded to particularly areas that were having real dramatic surges in COVID-19 cases. And that was, again, working closely with our state and territorial and county public health partners. Point of care reporting. This was something, honestly, that there was a little bit of a disagreement about within the CDC, is just how important it was to try to capture data on every single case. I was actually one of the people at CDC that sort of was advocating, well, it's great to capture data, but this is really the first infectious disease that we sort of tried to capture every single case. And I felt that actually just getting point of care and over-the-counter tests out there to identify infected people so that they could, do the appropriate isolation and prevent the spread of infection was actually more important than capturing every single case. Data analysis, I mentioned that this is something that was just so cool that that I had access to this amazing in-depth data analysis that the CDC was largely coordinating. And then we talked about drafting testing policy in collaboration with the White House and the CDC. Um, so this is just an example of the kind of data that I would get literally every single day. And so this is a scatter plot of looking at 12-day testing results on the vertical axis versus new cases per 100,000. So I had this broken down by every single state, every single territory, down to the county level about really where the hotspots were, and also how that correlated to the social vulnerability index, which is largely related to income level and other areas. So this was very, very helpful in terms of guiding where to prioritize the free testing capability that we had. ICAT, actually, there were 4 sort of initiatives in ICAT. The biggest, which I think was probably maybe $8 billion of the $12 billion I had for ICAT, was in collaboration with CVS, Walgreens, and eTrue North Pharmacy, which is a pharmacy chain in the Midwest. So we did a huge amount of free testing, in stores there. We also did surge site testing, and often these were set up in, for example, like Walmart or Costco parking lots, areas where they were having just explosions of cases. And then we also did pop-up testing at specific events like concerts, and I'll show you in a minute NASCAR races that started basically being resumed in 2021. And then it said we also had about maybe $3 or $4 billion of school screening testing that we did through ICAT as well, although the bigger proportion of that was done in this later program, this Operation ET. So as I mentioned, I think before some of you arrived here, that in, I think it was May of 21 or June of 21, NASCAR actually approached the CDC and said, hey, we're going to start stock car racing again. And, one of the things that we thought, and I was very happy that NASCAR asked for this, is we would like to basically, require that, if we don't actually require maybe, but that we strongly encourage people to get vaccinated for COVID-19. So we would actually like to set up, on-site COVID-19 vaccination and also COVID-19 testing for people that want to make that available. So we work mainly with our local, county, and state partners to do on the vaccination side. And then the CDC, my ICAT team, raised their hand and volunteered to basically field testing through the ICAT program. So anyway, I thought this was really cool, as did a lot of my people that worked for me, including Joe Miller, who was actually from Talladega, which is in northern Alabama. So he was all over it and wanted, and asked me specifically if he could lead the ICAT testing team at the Talladega raceways. And I told him, I said, well, I think that'd be fine, Joe. And he's, by the way, a scientist at CDC. He's a microbiologist. Was his day job. But I told him that I wasn't going to sign off on his expense account unless he had to watch this movie first. And so this was the required education. This is Talladega Nights with Will Ferrell. So anyway, the ICAT program, I think, was really a huge success. And it's still actually, I think, maybe ongoing, in a small way. As I said, though, I haven't had a lot of insight since I left the CDC last July. So the other big operational program was Operation Expanded Testing, which was, again, the main goal of this was to allow public schools to safely reopen by doing serial testing of both staff and students. Initially, depending on the prevalence of cases, in the local area, could be either every 3 days, every 5 days, or once a week, depending on the threat. We actually had 3 contractors, Battelle in the Midwest and the Mountain States, Perkin-Elmer on the West Coast largely, and then in the Northeast and the South, we had Eurofins. And I'll talk about this in a little bit, but this was actually also a very successful program. And again, I think my budget was about 8 billion for this particular program. Um, so the thing again, that I just loved about my coworkers was the fact that they really were just such wonderful, dedicated people. And remember, they're TDY, or they're doing temporary duty away from their homes. Most of my CDC folks were Atlanta based, so they would actually leave their families for usually 4 weeks, and then they had. I think we did pay for their travel once a month to go back to Atlanta to check in with their family and have a long weekend. But this really was a sacrifice for them to make. And of course, people like you guys in the military know what it's like to be away from your family. But the morale, I think, was really good, and I just was really inspired every day by working with these folks. One of the things that I loved about particularly my CDC colleagues is just their gentle kindness and sense of humor. So when we named Operation Expanded Testing, we deliberately used this guy as sort of our emblem. I think those of you who remember this movie know it was like one of the sweetest movies ever, and that this person or being was really kind of emphasized unconditional love and kindness. So we all totally embraced this guy with our testing program. So when I again took over, basically in May or so, of trying to run the group, that things were again, cases actually were at a very low point at this point. But again, I wasn't convinced, and I think most people at CDC, that we were not going to have more waves, and particularly as variants emerged. So one of the things, though, that I did put together a budget, initially requested 3.5 billion, since the ICAT was going to end at the end of 21, and then Operation ET was going to end, I think, within basically June of 22. So I wanted to have a continued testing budget that we could use to continue some of these programs, but also expand testing in other areas where we really were hurting. So one of them was again in nursing homes and skilled nursing facilities, as well as assisted living facilities. So I think you probably remember that there were really large numbers of deaths, particularly in elderly people, who were more prone to getting very sick with COVID-19, and often despite vaccination. So I did fund, or was able to get money for point of care testing in skilled nursing facilities. As I mentioned, the number of unaccompanied children dramatically increased in 2020 into 2021. So I wanted additional resources for unaccompanied children. I also wanted to be able to continue the Operation ET program by hopefully safely opening public schools. And then federally qualified health centers. I think many of you may or may not be familiar with that term, but FQHCs are actually federally funded health centers. So we have a couple of them, in this local area. I think 3 or 4 of Santa Clara Valley Medical Center's clinics are actually FQHC centers. So these are largely centers that focus on healthcare for uninsured or at least underinsured people, both in metropolitan areas as well as in rural areas. We also wanted to distribute free over-the-counter tests through food banks, again, trying to reach the vulnerable populations. Just backing up a little bit, that, after Julie and I got back from Antarctica in February of 2020, and I went immediately back on the wards, caring for patients, that I was just so struck by how many Latino patients that we had, who were getting sick. And a lot of it was pretty obvious that they didn't have the luxury of working from home. These people worked in service industries. They were the ones loading the groceries, on the shelves. People, working as cashiers in stores and things like that, or cleaning people's houses or cleaning buildings and things. So they didn't have the luxury that people like us did, that we, could work from Zoom. And so, and often because they were poor and lived in multi-generational homes and things, with 10, 12 or more people in the same household, that the Latino community in this area anyway, was really heavily hit. So, again, one of my thoughts was that, we really wanted to get free test kits out to people who could really use them and were high risk. So, distributing through food banks was something that we did. Also, because I had such a good budget, I actually funneled some money back to NIH to actually look at viral variants. And actually, Bruce Stromberg and his team developed some really interesting assays to rapidly characterize potentially emerging viral variants. So that was kind of fun scientifically. But again, one of the kind of headwinds that I was up against was that in May and early June, of 2021, the cases in the United States of COVID-19 were at a very, very low level, as were hospitalizations and deaths. But again, even though I'm an optimist from the Midwest originally, that just I was worried that the other shoe was going to drop. And again, right around like the end of May, this Delta variant began emerging in the Indian subcontinent. And I remember just reading in the lay press as well as in like MMWR that like over a period like of basically May of 21 or March of 21, less than 7 sequence cases in India were Delta variant. But by the end of May, it's like literally this variant just exploded, and it was a bad bug too. High rates of morbidity and mortality. So I asked my CDC modelers, I said, is this something that we should be worried about coming to the US? And they all said, oh yeah, Dean, this is going to be bad news. Well, I had, a daily phone call, a Zoom call with the White House. And again, I had my modelers at least on one of those calls. And then I presented this requested budget that I had put in for the 3.5 billion for over-the-counter and point-of-care tests. And I just assumed that they would, oh yeah, sure, it's compared to what you spent before, it's really not that much money. But I really got kind of shot down. I didn't take it personally, but anyway, it was a rough call. And anyway, so I basically said this, hey, this Delta variant they're seeing in India is going to hit us hard. And I showed, of course, a separate slide, with my proposed budget of what I wanted to do with the 3.5 billion to procure rapid tests for vulnerable populations. But again, I won't name the person's name, but she told me in a very like disparaging tone, she goes, Dean, she goes, no, that much money has bad optics, bad optics. And I'd kind of never heard that expression before, but I guess you all know what that means. So I took it kind of hard, and it was about maybe 11 o'clock in the morning. I got off the call, and there was this really kind of fun restaurant that served fish and chips and British beer. So I took an early lunch break and had a beer for lunch that day. But when I got back, Joe Miller, who again was my ICAT lead, and Mary Holscher, who was my main finance person, they'd printed out this photograph from the 1970 movie MASH, which you all know about. And anyway, it's Elliot Gould and Loretta Swit and Donald Sutherland. I think were the three there, and they wrote on it, said, Dean, just remember, we're the pros from Dover. And there was like a joke because I'm from Dover, Delaware. But anyway, so that made me smile. But literally, I was real close to quitting. But when I came back from lunch that day and they'd posted this on my door, I decided I'd stick around. And I think you and I talked a little bit after that. So this was the budget that I was given, and still a lot of money, but they cut it from 3.5 billion to 890 million. And again, I think I'd already talked about these, like what I wanted to do with that money. But then what really was bad was that by July, Delta was off to the races in the US. And now all of a sudden, hospitals are absolutely overflowing. The ICUs are overflowing. At Stanford, they actually opened up 2 closed wards and turned them into ICUs. So it was pretty intense. And then, so that actually happened, in the summer of 21. And then, of course, Omicron hit a little bit before Christmas time of 22. Then some of you may have seen this article in the New York Times and Washington Post, but this was probably early July or late June of 21 that this kind of got out to the world, that Abbott, which was the largest manufacturer of both point of care and rapid or over-the-counter diagnostics, um, was probably found out, I'll bet the same day that I got yelled at by the White House on the conference call, because I'm sure Steve Santos called Abbott and said, hey, guys, I know you were counting on, 3.5 billion, but bad news, it's only going to be, 800 million or so. I think they made the decision fairly quickly, and then it came out in the papers a few weeks later that they closed 2 of their 5 diagnostic manufacturing plants, laid off 1,500 employees, and destroyed inventory. And then, of course, by July, now Delta is off to the races, and people are dying. And then now government's being asked, like, how come you don't have enough diagnostic tests? But anyway, I never publicly, except in this lecture, said, well, I told you so. But it was pretty stressful. This is actually just a photograph I took of the whiteboard that was outside my office, and this was probably taken in August of 21. And so I was able, though, to pretty quickly get more money out of the White House. So they gave me an extra 750 million to continue ICAT longer than it had been budgeted for. They gave me an additional 1.95 billion on top of the 889 million for point of care tests. And then I think in August, or no, September, they gave me another 1.1 billion for more over-the-counter tests. And then I was also given another 126 million for what I call the long budget, and this was to help fund TDG operations and Operation ET technical assistance, basically coordinating between the 3 hubs that were coordinating Operation ET. And then just before the group shut down in December of 21, it was given another 2.3 billion for, again, supply chain, and particularly to replenish the strategic national stockpile. We also had some money for a biorepository at NIAID, and then some money that was able to funnel to both BARDA and RADx, and then also some additional money I wanted for purchasing of multiplex assays, which I think are also important as well. So anyway, I'll close out this part, and I won't go through every name, but these are just some of the 82 people that I worked with during the last few months that I was in that job, and it really was an amazing experience. Just shifting gears a little bit. So one of the things also that was kind of fun about living in DC was, uh, I won't bore you with the whole long story, but I've known Tony Fauci since 1978 when I was a medicine resident in Wilmington, Delaware. And I'd actually sent a patient in 1978 who had necrotizing vasculitis, a disease we used to call Wegener's granulomatosis, down to NIH, where Tony was studying Cytoxan versus prednisone to treat vasculitis. And he actually wasn't not head of NIAID yet, but he was head of the Laboratory of Immunoregulation. And then in 79, when I was like the acting chief resident in Wilmington, we had a grand round speaker that canceled with like less than 48 hours notice. This grand rounds is a formal lecture, and I think the talk was Wednesday morning. And Sue Ruggiero, one of the secretaries of the Department of Medicine, let me know like at noon on Monday that the speaker had canceled. Do you think you could find somebody, Dr. Winslow? And I said, yeah, let me think about it. And at first I thought I'd invite just one of the local docs to give a talk. And I said, I wonder if there's any way that Tony Fauci would consider taking the train up from DC up to Wilmington. So I called the number, it was that was on the progress notes that I get on Mr. Bledsoe. It was the name of the man that had the vasculitis. And I thought, I expected a secretary to answer the phone. But again, Tony picked up like on the second ring, and hey, I can't imitate his Brooklyn accent or Bronx accent, but he goes, oh, and I kind of go, oh, sorry, Dr. Fauci, this is Dean Winslow. I thought, I would just leave a message with your secretary. And he said, no, yeah, just thanks for calling. He goes, yeah, your buddy, patient Mr. Bledsoe, he's doing great. He's doing great, And so I think so then I fessed up and I said, Dr. Fauci, I know this is really rude to ask you at the last minute. Is there any way you'd consider, taking the train up to Wilmington Wednesday morning real early and given medicine grand rounds on vasculitis. And he goes, yeah, I should be able to do it. He says, unfortunately, I probably can't stay and make rounds in the hospital with you afterward, but that should work out fine. Can you pick me up at the train station? So I met him at the Amtrak station in Wilmington at 7:30 that morning, and he gave this great grand rounds. And then we had a cup of coffee, and then I drove him back to the Amtrak station in Wilmington. So we've kind of been friends ever since. And then, he had me serve on, during AIDS, which was the big thing that hit like 3 years later. So anyway, so when I was in DC in 21 and 22, I got together with him a couple of times, and it was really fun. And the guy on the left, that's Cliff Lane. And Cliff was actually, I think, in the lab with Tony when I had called that night in 1978. They've worked together for a long time, and Cliff's just a lovely man. Then the other person, that's the Julie's big day. That was when Julie got the big induction ceremony for the National Academy, and of course Julie is known Fauci as well. So you got that picture together there. And then this is Henry Masseur on the left there, and he and I are the two troublemakers that started the IDSA sepsis task force, trying to get doctors not to slam everybody with broad spectrum antibiotics just because of a high white count or something. So I got together with Henry a few times. And then that's my CDC boss, Dr. Rochelle Walensky, who just announced her intention to step down, in a few more months. But she was a great boss. And she actually kind of gave me a heads up that that the group would be winding down by the end of 21, but asked me to specifically to stay on board and do some other things, including, and already had started basically being the chief medical officer for the Southwest Border Migrant Health Task Force. And then she also asked me to basically be available for other things, and that other thing didn't take much longer. So I think this photograph was probably taken in April of 21. And then I think everybody remembers about the middle of August of 21 that basically Kabul fell to the Taliban. And these were just, file photo, just the chaotic scenes. And I think all of us, and you guys both served downrange, right, in Afghanistan. And, just remember just how it was being there. And I think all of us that had served in Afghanistan were just heartbroken and devastated by what happened. And not to talk politics too much, but basically Trump, by the Doha Accords, put this in motion that we were going to withdraw. Originally, I think the date was March of 21, and then Biden extended it, but still, it was terrible. I think the way that we really abandoned our allies in that country. So just this is of course 9/11, and all of us here are old enough to remember what a terrible day that was. But I think one reason that many of us, were motivated to continue to serve even longer than we had to was the fact that we believed that our wars in Afghanistan and Iraq, not just avenging, but hopefully preventing another attack by terrorists on our country. And this is, sorry, it's a little graphic picture, but another reason that I think many of us served was because we felt that we were really helping the people of Afghanistan and Iraq. And by the way, this is what women's rights looks like under a Taliban rule or an ISIS rule. This is a 19 or 21-year-old mother of a 2-year-old who's basically his husband poured gasoline on her and lit her on fire. So this is what happens under the Taliban regime and things like that. So I think when we saw Kabul fall, it was just heartbreaking for those of us that really put our hearts into this. So these are just some pictures, and this is Bagram Airfield, the upper left. Upper right is I think that's Fob Salerno, down south, with some Afghan National Army soldiers. And lower left is in, I think, probably October of 2004, when I was actually asked by Central Command to be President Hamid Karzai's doctor while he went around and gave speeches. He really didn't want to leave Kabul because every time he did, someone tried to kill him. And so he said, the only way I'm going to do it is if you assign a U.S. Air Force doctor to be my personal doctor. So I did that for a few weeks. And then lower right is, again, a child that I took care of. Just again, typical scenes from downrange. This was actually from Iraq, not Afghanistan, but again, what it was like. This is my medics pulling a wounded soldier off a medevac helicopter, and this is what a mass cow looks like in a trauma bay. And then this is me helping out our general surgeon. We only had a general surgeon, an orthopedic surgeon, anesthesiologist. So once things quieted down, and I often would scrub in with the surgeons because they were really shorthanded. Sadly, we couldn't save everybody, and these are the kind of scenes that I'm sure you guys remember as well. I went to way too many. We called them Patriot details. I don't know what you guys called them, but basically where mortuary affairs, takes the casualty in a transfer case, draped with a flag, and people who are available, come out to the flight line and slowly salute as the transfer case is loaded on the C-130. And it's just heartbreaking. And today, I can't even read the words of the 23rd Psalm without crying. And also I was in Afghanistan in May 2nd of 21 or 2011 when President Obama ordered basically the SEAL team to leave Afghanistan and fly to Abbottabad, Pakistan, to kill bin Laden. And I was actually on alert that night with my crew. We didn't know what was going on, other than something was going on. But we learned about it the next morning, along with the rest of the world, what had happened. Honestly, I think a lot of us that were downrange then thought the war we won. We have won the war. And I remember walking out actually to fly a mission that afternoon after I got done working in flight medicine clinic, and saw this rainbow of a shower had just passed over, and I'm looking over to the east, toward the runway at Bagram. The runway there runs, I think, 03 and 21. And I remember thinking that honestly that this was a sign from God that we had won the war. So anyway, we actually, when we flew home in our C-130s a few weeks later, we actually got to take our aircraft back with us. We all changed out of our flight suits into blue jeans, which is totally against regulation. But we won the war. And then I remember one of the young enlisted loadmasters came up to me, after the aircraft commander, who was major, said, "All right, men, get into your blue jeans." And this young enlisted guy came up to me and he goes, "Colonel," he says, "can't we get in trouble if the Air Force finds out that we're flying these C-130s wearing civilian clothes?" And I said to him, "What are they going to do, Sergeant? Make us get short haircuts and send us to Afghanistan?" So that's still kind of an answer that I give to people, like when I do something, as we say, non-standard in the military. But anyway, so these are just some of the scenes. I couldn't believe when, again in August, one C-17 crew fit 937 Afghan refugees, into one of these C-17s, fleeing Kabul International Airport. Let's see. Kate, why it's not advancing here, but oh God, it's amazing. So again, I actually stepped forward to actually do the testing for COVID-19 of all the refugees as they started arriving at Dulles International Airport outside of DC. And this is a photograph that I took of the very first plane load of Afghan refugees. So again, I had my ICAT team there, essentially 24/7, while these planes arrived. We also had sites at Philadelphia International Airport. There was a few weeks later, they actually started sending some of the planes to there as well as to Dulles. So at least for me personally, this was very healing to know that maybe I was making a small difference, but it's just heartbreaking for those of us that I think, spent time downrange. So a little bit about the safe haven bases. So people actually spent an average of 1 to 2 weeks either at Al Udeid Air Base or sometimes in Ramstein, Germany, before they actually came to the US. And then they were temporarily settled at these 8 different military bases all around the US. And of course, my job as basically the senior CDC advisor to Operation Allies Welcome was to interface, and usually it was twice-a-day conference calls with one or more of these bases to help them with different issues. Some of the infectious diseases that we saw actually usually these were at the lily pads, so either at Al Udeid or Ramstein, because the vaccination rate for measles is so low in Afghanistan. So there were some outbreaks of measles in children that occurred. But we didn't have any measles outbreaks in the US because, again, they all got vaccinated before they came to the US. This is Koplik spots here. We also, and I was not surprised about this, saw a fair amount of TB, tuberculosis, in the Afghan refugees after they showed up in the US. So I made sure that we had robust screening and treatment protocols in place. And again, I was just so impressed the way every state, local public health department, and TB expert in the local area stood up and helped us care for these Afghan refugees. So again, this was actually a picture I took at Bagram at the DFIP, the detention facility in Parwan, which was just northeast of the runway at Bagram. Back when I was there in 2011, I was there as a flight surgeon, but I also was the only infectious disease doctor in the country. So I helped advise the Army on TB treatment and screening back then. And yeah, and then we also saw occasionally some interesting tropical diseases in refugees. This is leishmaniasis. And again, we had great help from University of Minnesota, from their tropical medicine department, helping us manage those, as well as DOD's. So again, one thing that was really kind of upsetting to me, this is in February of 24. So 6 of the 8 safe haven bases is closed, and there was only at that point maybe 12,000 Afghan refugees at the 2 remaining safe haven bases, but still airplanes were coming over like maybe once every 2 weeks. So the Department of Homeland Security decided to open up this largely inactive conference center in Leesburg, Virginia, which is about 10 miles north of Dulles Airport. And so I was asked by Department of Homeland Security to basically go out when they were going to have a town meeting to reassure basically the local folks about this opening this center in Leesburg. So I got there, again, thinking this was going to be a really like a feel-good kind of a meeting, and maybe people would ask me a few questions about what type of infectious disease screening had gone on and that sort of thing. But I was just so shocked that, again, person after person got up to the microphone, and they had all these conspiracy theories about, we don't want this in our neighborhood. These Afghans, they're going to rape our school children. They're going to give us diseases. They're terrorists, and it just on and on and on. And it's like, I just couldn't believe it. And so I was so upset that I wasn't going to normally have a speaking role unless, maybe at the end people had questions. But I got so upset that I raised my hand and I asked the mayor of Loudoun, Virginia. I said, "Can I talk?" And she said, "Sure, Dr. Winslow, come on up." And I got up to the podium, and I had my HHS ID badge on, kind of like this, and I actually slammed it on the counter on the lectern. And again, I had tears streaming down my face, and I said, "I just want you to know, I am not speaking as a CDC employee. I am not speaking as a representative of the US government or Health and Human Services. I'm speaking as a veteran of Afghanistan." And I said, these are good people, and we should welcome them with open arms. And I didn't know that at the time, but there was a Washington Post reporter there. So, you can look that up. But, I won't read this whole thing, but I just, again, I said that these are good people. In many cases, they saved the lives of Americans. They put their lives and their families' lives at risk, to help our war effort. We have to do this if we're going to do the right thing as Americans. So a couple more people then got up after I did and said, again, more negative things. And then one person, there was actually a woman Methodist minister, she got up and she said, "This is a wonderful opportunity for us to basically be Americans and to practice our Christianity." Anyway, this I haven't seen the movie yet, but apparently it's a really powerful movie, and it talks about the relationship between a platoon sergeant and his Afghan translator. But I do have a little personal experience. The guy in that picture there is probably taken in maybe 2012 or so, and his name it's a long name, but he goes by Q. And Q was a translator assigned to a U.S. Army infantry unit, and he was actually blown up by an IED and then shot and spent about 4 months at the Craig Joint Theater Hospital at Bagram. He was actually there when I was there in 11, but I didn't take care of him. But he was one of the hundreds, maybe thousands of Afghans, who got wounded or killed working with coalition forces. But he was able to get to the U.S., I think, in maybe 2017 or so, and was working as a security guard at Stanford in Washington on Connecticut Avenue. So you know, he's just a wonderful man, and it was just an honor. And anyway, I'd go out and run in the morning, and he'd tease me. He goes, "Yeah, looking good, Colonel." As I have my Air Force PT gear, I still wear. But I'm glad he got here. So anyway, this I'm not going to read the whole thing to you, but this is Matthew 25, which was read by that Methodist minister who spoke at Loudon shortly after I did. And I remember this because I did pay attention in Sunday school when I was a little boy. And then the last job, and I'll close with these last few pictures, was being the chief medical officer for the Southwest Border Migrant Health Task Force. And these are just, again, some photographs of children, crossing the Rio Grande. And really in unprecedented numbers, since early 2020. And I think the numbers went down and now are going up again. But these are desperate people, fleeing horrible conditions in Central America. Again, not just poverty, but violence, and just terrible things. And also, by the way, climate change may be making the conditions worse in Central America. So this is, again, something that I was very happy to take on in addition to, my TDWG duties. So again, these are just some photographs. So majority of the unaccompanied children are from Guatemala. Next largest number, Honduras, and then after that, El Salvador. Actually, Mexico is relatively low. But as a parent and grandparent, I can just imagine just what an anguished decision it would be as a parent to basically entrust your precious child to a coyote, to take him across the border with just the chance that they could get asylum and get resettled with relatives in the U.S. So then one of the things that really upset me about the Trump administration was how just that the Trump gave license to all of this, hateful white nationalism. And again, this guy is no longer on the air, but again, this is big, into replacement theory, things like that. These are the Tiki Torch people in 2017 marching in Charlottesville. This is the President Trump's wife when she visited the southern border in 2020, and her jacket says, "I really don't care, do you?" And it's like, doesn't that offend you? But so anyway, that I can't, as a Christian myself, I'd never understood, and I'm still so disappointed that the religious right has embraced Donald Trump. He doesn't know the difference between an epistle and an apostle, probably. But I'm proud to be a left-wing, instead of a religious right, I'm a religious left member. But again, this is an Episcopal church. So I'd walk by this church on my way to the metro every morning when I lived in DuPont Circle, where again, this is like now considered liberal stuff. But when I was a boy growing up in the 50s and 60s, these are Republican values. The Republicans used to be the party of civil rights. They were the party of the Women's Rights Amendment, the Equal Rights Amendment. That was a Republican initiative, not a Democrat. Ronald Reagan said that we need to keep the government out of the boardroom and out of the bedroom. In other words, he believed in gay rights. President Nixon created the Environmental Protection Agency, the Endangered Species Act, quadrupled the funding of NIH. So Republicans used to believe in science. And anyway, so this was back, just a couple more slides. So this was going back, this is Bloody Sunday of March 7th, 1965. And just to show you just how much things have changed. So these were civil rights marchers that were marching from Selma to Montgomery for voting rights registration. And I can tell you all those white cops that are beating those people, those are all Democrats that are wielding those batons. So just tells you how much things have changed over the years. Then last thing, so that guy number 37, the next to Coach Ginsburg and Coach Nevins, that was me on the varsity football team at Dover High School in 1969. So I think all you know, I'm not the smartest guy in the room. So I blame getting hit on the head too many times for why I had such low SAT scores in the program. But anyway, so this is another person that my kids all think that I'm really Forrest Gump. So I love Forrest Gump. And this is the Dean Winslow Forrest Gump simplified version of Matthew 25. I was a refugee and you welcomed me. So it's pretty clear what we're supposed to do as human beings. Anyway, I'm just going to close real quickly. The task here was basically that I saw it. So 5 of the 9 Customs and Border Protection sector stations were where like 95% of the unaccompanied children were being initially detained. My goal was to get them out of there safely, preferably within 24 hours, so they can get to an emergency intake shelter run by HHS. But again, I didn't want to create, COVID outbreaks. So we basically set up rapid screening at these 5 of these 9 sector stations. And we would segregate kids to either go on a cold bus if they were antigen negative, or a hot bus if they were presumably infected and had a positive test. So it really worked out pretty well. And again, I got along great with the CBP people. So again, Customs and Border Protection is basically it's law enforcement. And whether you like it or not, it's a very macho kind of masculine culture. But if you understand it, you do just fine. But they do care. It's not like they're uncaring people. But anyway, we had a conference call every week with all of the commanders of the sector stations. There's one though, generally though, we did these calls by Zoom, or actually by Teams meeting, I think it was. And generally, we would all have our cameras off, and so you could be multitasking if you weren't, having to talk on the call. But this one particular day, this one CBP officer was being really rude to Ellen Kirsch, who was my lead for the border testing. And she's actually an STI scientist at CDC, and just very lovely and smart and everything. But this guy was just being a jerk to her. And so again, I got my video off, and it really made me mad. So I turned my video on, and at that point I was still on active duty, with the California Guard, and wearing my combat uniform, which you wear while you're deployed. And I never wore actually a medical corps insignia on my combat uniform. I always wore my aviator wings. So all of a sudden, the guy who he thinks is just some CDC egghead, now he comes on screen. And finally, and I said to him in my deep voice that I can put on artificially, I go, "Officer, listen up. Let me tell you how we did this downrange in Iraq." And then all of a sudden, it was like this guy comes to attention. He goes, "Yes, Colonel, Roger that, sir." Like that. So anyway, he was a lot more respectful on all future calls. This is a EIS shelter, and I spent a couple of days down at Fort Bliss. Amazing, like 3,000, 4,000 kids. And they were treated with amazing kindness. Average, we kept them about 7.5 days before, finding relatives in the U.S. to which they could be resettled, and very, very impressed with the way that the kids were treated there. So anyway, I'm just going to close there. Thank some of the people that I work with. I won't go through all these named agencies, but Ann Shookett, who was a principal deputy director, hired me, and then Michael Iademarco was my boss the first 2 months that I was there at TDWG. But it was really a great experience, and I'm also grateful to Stanford for giving me a year and a half off to go do this. So thanks.
Thanks so much, Dean. So we want to open it up for questions, and I want to invite our colleagues that are on Zoom to put a question in the Q&A, and I'll monitor those. But anybody in the room have anything they want to ask Dean? Sure. We're going to give you a mic so our colleagues on Zoom can hear.
Dean, that was really an extremely moving presentation. Thank you very, very much for all of that. And I just want to register surprise, number one, because I had understood that those centers where the children were held were actually kind of holding pens, and they ended up being there a long, long time. But you say they're in and out of there in an average of 7 days, assuming relatives can be found to resettle them. But I think that's really terrific.
Yeah. Yeah, so just real quickly, so the CBP sector stations, they're more like, holding cells. And again, our goal was to try to get them out within 24 to 48 hours at the most. But the EIS shelters were actually, set up early in the Biden administration, and they were run by Agency for Family and Children under HHS. And again, it wasn't luxurious, but we had like, separate tents for girls, separate tents for boys, and then of course, separate facilities if they were COVID positive until they could come out of isolation. But when they first arrived, the first thing, it was just so beautiful that there are signs in English and Spanish. Welcome to America. We are glad you're here. Yeah, welcome to the United States. And then they would be given basically a backpack full of really nice clothes, not prison uniforms, but nice clothes that, nicer than, as nice as what my kids wore. And then, they were given a psychological assessment, including, screening for PTSD. And remember, a lot of these, particularly girls, have been sexually assaulted during their journey and stuff. And then the second day, they actually underwent an educational assessment. And they started out actually like they had school set up, so they actually had classes that they'd start probably by the second day that they were at the EIS shelter. And, meanwhile, there was a social worker assigned to each child, and who's also, trying to track down relatives in the US so they can be a safe disposition. And they said, when I stepped down from that job, in early 22, the average time at the EIS shelter was about 7.5 or 8 days or so. So they weren't there that long.
Really, really good. I actually did have a question about the earlier part of your briefing, and that was, I've been wondering right along, how hard was it for you all to sell the big corporate drugstore companies like CVS and Walgreens on setting up these points for testing and for vaccination as well? I guess they'd already started opening up their medical clinics, but I just wondered, because for them that was a bit of a departure to suddenly be this giant public health center.
Yeah, it really was. And again, CVS and Walgreens and Eat True North were the three main ones, and they really seem to embrace it. And again, we tried to though focus our testing sites again in areas of particularly of cities and that had this high social vulnerability index. Basically a lot of poor people and disadvantaged people. But so I was very pleasantly surprised, again with our the interaction and the way that these three conglomerates work with us. Yes, sir.
Well, Dina, that was tremendous. Thank you for sharing as personal a set of stories as you did, and for doing what you did. I thought was both disturbing and moving was the story of the refugees showing up north of Dulles, I think the name of the town, and people concerned about health, but then also utterly ignorant about who these people were, and stoking hatred and biases in some of the public statements they were making. It led me to wonder whether, in your experience in the military, you're in a particular unusual unit, but there are many people who are concerned about the conservative Southern numbers in the U.S. military today, and how the U.S. military is not representative of the public in the United States, but rather certain segments. I don't know whether the other officers here would feel that way. Did you have a sense that you were pushing upstream to get your views about either refugees or about Afghan civilians shared by others?
Well, getting in the, yeah.
Internal military conflict.
Yeah. So again, I think, all of us, particularly that had served, downrange, we grew to love, our translators and the, medical liaisons that I worked with, particularly outside the wire in Iraq. So I think actually that, particularly people who had served downrange are much less likely to be prejudiced because they saw firsthand, again, people like, Q, the guy that I talked about, or like I say, this movie I haven't seen yet, by Richie, talking about that. So I think, your first part of your question there, you're talking about just some of the demographics of particularly who serve in the enlisted ranks in the military. You're right that, again, people from the Midwest and the South tend to go into the military service more, let's say, than people from the coast. But, it's still, though, the U.S. military is just incredibly diverse. The fact that the Air Force Chief of Staff, General Brown, who I met, in Hawaii when he was the PACAF commander back in 2019, is African American. He's going to become, the basically the chairman of the Joint Chiefs of Staff, in a few weeks here. So I think you'd be surprised just how open the U.S. military is. In fact, in a way, very liberal. And I always joke that one of my old fighter pilot buddies, who's long since retired, again, he's from the small town in Kentucky, but a really smart guy. And anyway, and he's so funny. And he told me a few years ago, he goes, Dean, he goes, I have to admit, he goes, politically, I'm far to the left of Mao Zedong. This is again a guy from Kentucky, who flew, combat in Vietnam and in later wars too. So the military is a lot more diverse, but it does bother me though that there's this perception, and we were talking before you came in that this, Senator Tuberville is like holding up all these promotions because he doesn't want women to be given the freedom to leave their base and get a therapeutic abortion in another state. So I think it's really, the problem is more outside the military than inside. Yeah, David, I'm sorry.
Dean, I'll just echo what I think others have said or might say, but thank you. And were there only many more of you out there? I know that you walked into this position in the testing arena partway through the pandemic, but we all remember the early days and how the testing capacity unfolded at the start, which, to put it bluntly, I think left a lot to be desired. The testing capacity that the CDC rolled out initially was woefully inadequate, too sparse, too late, flawed, etc. And I think it illustrated to many how we as a nation had failed to prepare properly for an event that many foresaw in many of the ways that it actually unfolded. And now, though, you've seen what it looks like inside and throughout and what could be and what can't be, at least so far. So my question is this: if you were put back in charge now of a future diagnostic effort, national effort, and you were told that on December 30th of 2023, another pandemic will unfold. Won't tell you the agent.
No.
To be determined. What would you be doing right now to get ready so that we're much better prepared and have much better situational awareness than we had, I would say, throughout for that next one?
David, you wrote the book on it, so
but you have a perspective that I don't,
Yeah.
and I think you've seen a lot of the, the inner workings,
Yeah.
the many of us can say what we would like to have seen, but to know what actually would allow that to happen is something you could comment on.
Yeah. So again, with that, the kind of the debacle of the very early testing, like in the spring of 2020, some of that was driven by the fact that there really was, I think, a lack of expertise of true like assay development using what we call, GMP, good manufacturing practices. Actually, I did work in diagnostic device regulatory for a short period of time in the late 90s, early 2000s. And they had actually PCR contamination in their laboratory, which was one of the big problems. So that's kind of a um, an unfortunate unforced error, but also because I think the CDC sort of was trying to reassure people we've got this under control. That private industry did not step up right away. We were actually fairly lucky here at Stanford because we had Niaz Banai and Ben Pinsky, who developed homebrew assays that were able to fill the gap. But I think again, getting industry engagement early on is just so important. And that was one thing that we were able to do largely at the TDWG because we were literally talking to industry every day, and that they really did know that it was a true collaboration. Um, but the other thing, David, is that we've really underfunded public health in the United States, and sadly, the problem is like when there's no outbreaks, that the first budget that gets cut, in both state and county governments is often public health, and then you're really behind the eight ball when the bad event does happen. So I think we hopefully will not make at least the same mistakes, with the next outbreak.
If I may interject, the biggest debacle was the masking. Huh? Originally, even though I hate to say, Dr. Fauci even said maybe the masking. As soon as there was anything, to put everybody mandatory 95 every day, everywhere. We didn't have to probably even close all the businesses. And the economy has suffered to the point that it's going to be very difficult to, with all the money we printed and it's going to be it does work.
Yeah, well, masks aren't perfect, but they particularly prior to us having vaccines, they were helpful. And the thing too to remember about a mask is that a lot of people can have minimal symptoms and yet still shed the virus and cause infection to other people. And that's one reason when I'm working in the hospital, I always wear my mask, when I'm with patients. Is I think in a way it sends the right message, that you care about vulnerable people. So masks, you're right, they're not perfect, but particularly before we had vaccines, that they were a marginally to moderately effective means of preventing or at least reducing transmission. There's actually good physics behind it, showing how if you at least wear a mask halfway properly, it reduces aerosolization of.
Of course, the brightest point is how fast you're able to make the vaccine. It's incredible how fast.
Yeah, no, it was a real triumph of, particularly the two different messenger RNA vaccines that we had. So that's positive.
Other questions? Dean, I've got one. I mean, first, let me start by thanking you for your service, and it's inspirational. A question that we hear a lot is, are we better prepared now? And I have my own views on that, and as you know, I'm close, at least by marriage, to local public health.
Yeah.
What do you think about the CDC? Obviously, as David pointed out, they took a beating, and now Rochelle is leaving. You may not want to speak, publicly about it, but I just wonder what you think of the organizational capability and how's the CDC doing it? I mean, those from the outside are worried, of
Yeah.
course.
Well, I think my sense is, and I honestly, I didn't really work there long enough to kind of get an insider's perspective. I was kind of still always viewed, well, he's this guy from Stanford, who's he's a decent guy, he's going to
He's
work
pretty
with
good,
us for a
except he's
while.
from Stanford.
Yeah, exactly. But so I think there are a couple of things. I think the CDC actually did become too large and too bureaucratic, and that it just couldn't, really pivot on a dime. The same kind of criticism, gets levied, at the active duty army. That's one reason, you have special operations forces and things like that. But so I think that's one aspect. But the other aspect, though, was that I think it really got hurt badly during the Trump administration. It was just disempowered. I've known Bob Redfield for a long time, who was the previous CDC director, under the Trump administration, and he's a decent guy, and I think he really tried to do the right thing. But basically, the agency was just really hobbled, and they were specifically not allowed, to get their message out during the previous administration. So I think, the answer is not to have more politicians involved, so I think, just to summarize that, we really need to let our public health people be public health people, but also too, looking at, some of these organizational issues that, contributed to the sort of disastrous rollout of the early diagnostic, PCR molecular-based tests, and also maybe some of the problems with, mixed messaging that occurred later. So.
Great, thank you. I was really struck by your slide about the bad optics, and I guess from our perspective, a million dead people is really bad optics. And I don't know why that doesn't get more currency. Any last questions? I have none on Zoom, but anyone here? And if not, please join me. Oh, yeah, please go ahead.
Just talking, Dean, about the role of getting industry involved early. But I've been smiling every time I've done one of these home tests and see that it was made in China. And we're in the midst of this. Yeah, right. We're really pulling apart from China in terms of theoretically, in terms of business and manufacturing. So this is a bit of a mischievous question. How are we going to get industry involved if everything still gets made in China? Not only the tests, but all kinds of equipment and so forth.
Well, again, of course, Abbott, which was the largest manufacturer, Leon, they are a U.S.-based company, and they, up until they, prematurely laid off people and destroyed inventory back in the, in the summer of 21, I think they did a good job, and they, are probably still the biggest player. One of the things that I was really proud of is that we were able to get money to this Australian company that built a brand new manufacturing facility up near Fredericksburg, Virginia, which again, was employed, hundreds and hundreds of local people, and started producing, both point of care and rapid antigen tests, during that summer of 21. So I think there's a lot we can do to kind of incentivize onshoring of industry, not just in diagnostics, but in a whole variety of arenas. Good. Can I just tell you one last sort of funny story? So I was on a Zoom call, and the White House was going to join us, and this was not my daily call with the White House, but it was another meeting. And I think Fauci was on the call, and Francis Collins, the director of NIH, was on, and the head of FEMA, and the head of Jeff Shuren from the FDA was there. So it was a pretty senior group of people on this call. And again, the White House was a little late joining it. So we're talking, and I think it was the guy who was head of FEMA, we're all just talking informally, waiting for the folks to join us. And he said, this supply chain issue we're having right now with microchips is just really killing us, and of course, you remember it was car manufacturing plants were shutting down, and and he said, you guys, of course, I don't have to tell you, but microchips are really, a critical component of diagnostic equipment as well. And it's like I couldn't stop myself, and I said, well, gosh darn it, if Bill Gates didn't put a microchip in every dose of mRNA vaccine, we'd have plenty of microchips, So, and Francis Collins, he was drinking a cup of coffee. He laughed so hard he spit his coffee all over his computer screen. So anyway, that was my contribution to science that day.
They get picked up by Fox News. They finally admitted the truth.
Yeah.
Well, Dean, I think we've
Out of
about come
time.
to time. There's not a question in the chat, but there is this comment. We do not have a question, but we want to show our support for Dean Winslow from the 129 MDG. Thank you for your service and leadership. I think we all agree with that.
That's so sweet. Thank you.